So, John, you were giving us some follow-up on frozen shoulder?
Yes, mainly that is the coracohumeral ligament that you excise or incise during the procedure if you're doing it arthroscopically.
Okay.
One procedure you don't want to do is an open procedure. Uh, and actually, doing surgery on the shoulder is no better in a large study than just leaving the shoulder alone, because by the time you're doing this procedure, you're in a thawing phase, the third phase, and all you do is make things worse. So whether you do surgery or you do not surgery, usually patients try to talk you into surgery. I've had that happen to me, and I just, why don't you just wait, and you're going to improve.
Thank you,
So
John.
100% it doesn't occur. You always have some limitation of motion, mainly abduction and external rotation.
Thank you. Okay, I think this last time we were just ending on treatments of osteoarthrosis, and you can do non-steroidals, physical therapy, but eventually, if they can't control the pain with non-surgical techniques, then the surgical technique is really arthroplasty, and you can do a hemiarthroplasty, a total shoulder, using an anatomic approach where the ball is on the humerus, or a reverse total, which is non-anatomic, where the ball is on the glenoid. And then here we can see a traditional anatomic hemi. This is a reverse we see here, and this is more the traditional anatomic shoulder. So the indications for hemiarthroplasty is if you've got severe proximal fractures, but the glenoid is normal. If you have a lot of arthritis, but the glenoid is normal bone loss. Normally, this would just be for the glenoid side, but generally, if you have a lot of degenerative disease, both sides are involved. So in my experience, most of those go to a total arthroplasty. If you have a cuff tear, but most of the cuff is intact and early humeral osteonecrosis, you can do a hemiarthroplasty. Contraindications is if you have anterior superior instability, inadequate soft tissue support, and inadequate glenoid bone stock to be able to do that. Outcomes, generally the hemiarthroplastic outcomes compared to have decreased function compared to total arthroplasty. That's why most of the ones that we see are total, and they have increased revision rates. Total hemiarthroplastic indications, you have pain from primary osteoarthritis with intact cuff and glenoid, where you really can't control it well with non-surgical techniques. You have osteonecrosis of the humeral head and an abnormal glenoid, and post-traumatic osteoarthritis typically needs a total total arthroplasty. The reverse arthroplasties, typically you do reverse in people who have massive irreparable cuff tears with low demands. However, the deltoid still has to be intact in order for it to be a functional outcome. Contraindications is if the deltoid is significantly deficient, if you have infections, a neuropathic joint, and a non-reconstructible glenoid bone loss. Pre-surgical imaging in this particular paper, they recommended x-rays to evaluate the amount of degenerative joint disease. There are several classifications for that. And then, which I'm going to go through here because we don't really use those in decision making. CT you get typically you'll get CT to look for bone loss, and then here you typically use the Walsh classification, which several of our referring physicians do like to use on CT. And this really gives you the glenohumeral pattern of arthritis. And then you want to evaluate for the cuff muscles. And then an MRI, especially looking at the size of rotator cuff tears and the degree of muscle atrophy to help determine the patient's likely functionality after the surgery, and also to evaluate whether it should be a reverse or a standard. Complications. There's an overstuffing complication where the improper implant size was used. You can have complications from rotator cuff failures, paraprosthetic fractures, implant loosening, instability, and in reverse arthroplasties, you can get scalloping of the scapular neck or notching of the scapular neck due to impingement. Okay, so let's move on here. And Tayson, what do you think about?
Can I cut in a little bit, John?
Please do, John.
There are two types of prostheses. We now have no stem prostheses that are used, and you try to use a larger glenoid than the head, so you have not only rotational motion but also to and from. So that they compare it to riding a horse up and down or whatever. It's a comment that's made in Campbell's, but the glenoid is you don't use metal. What you do now is you use polyethylene, and the most common is it has 3 or 4 sort of like not screws, but made in a prosthesis that you can insert into the glenoid.
Yeah, there's a little plug
to stabilize it.
Right.
That's how you stabilize them. And also, the whole idea is to use cement if you have to in a glenoid, if the glenoid is not big enough or sturdy enough.
Okay. Thank you.
You're welcome. But there's everything that we're talking about in this has been talked about for 20 years, and there have been a lot of changes. So, but the old stuff, hemiarthroplasty stuff, and total replacements like near introduced in the 50s is no longer available for use.
Okay. All right.
Except in the museum.
Okay. Taysom, patient developed rapid, intense shoulder pain.
I do see increased signal in the muscle of the supraspinatus and infraspinatus.
Okay.
So, is this rapid development? Is it a strain?
Basically overnight. Just develop intense pain. What would your differential be?
It's either a strain or something neurogenic, right?
Okay. Okay. The patient didn't have a history of trauma, but certainly muscle strains you'd think about. So this is really kind of diffuse edema, more or less, in these two muscles. We know that these two muscles also have similar innervation, the suprascapular nerve, and this syndrome is called Parsonage-Turner syndrome. And
Okay.
it's not rare, but we don't see it that commonly. There are a lot of discussions as to what it is. It typically lasts for anywhere from a few weeks to 3 months, and then the patients usually get better. And most of the time, it's a complete recovery.
Okay.
People have talked about different pathologies. It probably has to do with some sort of a uh, neuropathy. Uh, Often people will go ahead and get an MR scan of the cervical spine. That can often be more confusing because in the age group of these patients, which is typically over the age of 50, none of them are going to have normal cervical spines. So then you get into a problem of trying to determine whether the cervical spine abnormalities are significant or not. Uh, but it's mostly really a clinical diagnosis. You do an MR scan, it helps out. This kind of finding really kind of helps confirm the diagnosis. But you're primarily looking for other causes of shoulder pain that might require other treatments, such as a rotator cuff tear.
Okay.
But
Uh,
this
uh,
is Parsonage-Turner syndrome. John?
I've always felt that some kind of a virus does this in multiple different muscles in the body. For some reason, they pick a certain muscle to aggravate.
Okay.
That could be a nerve um, viral problem or a muscle viral problem.
Yeah.
I have not. That's just a personal opinion, not something I read in the literature.
Okay.
Okay, so increasing shoulder pain for 2 weeks after upper respiratory infection. So our PD fat set images, we see increased signal in the infraspinatus and supraspinatus again. Yeah.
Yeah. So this is another Parsonage-Turner syndrome.
Mm.
And there is some correlation with upper respiratory illnesses. So John may be right. It may be either the virus or some sort of an inflammatory reaction triggered by a virus.
I think what happens is people don't take a good history and they forget to say that that patient has a cold or something like that because it's too mild a thing to worry about.
Okay, so 42-year-old male with pain and weakness, and on the, it looks like the infra infraspinatus and the supraspinatus, there's a edema and enhancement. So it subscap as well. Where is that?
So what do you think this is?
I think it may be something similar to what we just saw. Oh, okay, nerve entrapment.
Well, that's what they thought kind of clinically, but it turned out to be Parsonage-Turner syndrome. And it's also called acute idiopathic brachial neuritis. Um, and yeah, a lot of people think, as John said, viral or autoimmune as the cause of the neuropathy. Is a severe onset without a history of trauma. And you have pain, interesting, without weakness or paralysis. And the most common distribution is the suprascapular nerve. But I've seen cases that have just been the subscapularis and not of course, the suprascapular. And I've seen some in the teres minor before as well. And so MRI can be very helpful in confirming the diagnosis and excluding other possibilities. Okay, Robert.
All right, so we have a 41-year-old male with right triceps atrophy and no trauma. I think we're looking at the right brachial plexus. Looks like there's some, I want to say, one of the structures in that right brachial plexus is thickened and edematous. Yeah, right there.
Yeah. Okay. Here's some other images. When we go through it here, we can see there are a bunch of thickened nerves on the right side there. Here we can see them coming down here. And
I
on
like the word swollen.
fluid sensitive images, we can see increased fluid within the nerves or edema.
Yep.
Good. And this is called brachial neuritis. And again, it's probably the same etiology as the last one, that it's probably due to some sort of inflammatory reaction, possibly associated with viruses. You can also get brachial neuritis from trauma. In that situations, it's often called something else, and we'll see examples of nerve root avulsions and so forth when we get to cervical spine later in the year. Okay. Tayson. So basically right shoulder and kind of upper thorax pain.
Is there some sort of soft tissue interposed between the chest wall and
Are you
yeah,
talking about this
yeah.
and this? That's a good
Yeah.
That's one of the four joints
yeah.
in the upper body.
And we unfortunately I don't have both sides here. If I oops, sorry, that's the wrong one. If I had both sides, you would actually see that the scapula is differently positioned on this side than the other side. This patient also has a wing scapula, and this was thought to be secondary to viral neuritis as well. And there was weakness with winging of the scapula.
Okay. Okay, 10-year-old BCG vaccine, 7 months ago, left axillary mass. Okay, so yeah, in the left axilla, we see this lesion. It shows, I think we have contrast there, so some ringed contrast enhancement. Ultrasound shows, yeah, mixed echogenicity, maybe some fluid.
Okay.
So, okay. Different patient, similar thing in the axilla. So axillary masses, it could be adenitis in a kid, but I'm not sure.
Yeah, so this is sometimes called BCGitis, but it's a inflammatory reaction. Typically occurs at the vaccination site from BCG. I don't think we've ever used much BCG in the United States. So, but
It was very commonly done in the 60s for prevention of tuberculosis. They found out that it didn't work.
did they use it in the United States as well? Or
Yes,
just overseas?
Margie had a set
Oh,
when
okay.
she worked at when she was
A nurse.
in nurses training at the Herman Kiefer Hospital in Detroit that treated nothing but TB.
Ah, okay. Thank you.
So she's been positive every time she's had a PPD test, which they only had once. That was enough.
So we have a 2-year-old female with right chest wall swelling for 3 days and uncertain history of trauma. So on the upper image, it looks like there's almost like there's like maybe some fluid in between the muscle layers, and then let's see, 6 days later, more aggravation. So yeah, there's prominence of the right body wall, and then like so it looks like there's a collection there. Yeah, like some sort of collection within like the maybe the subdu or the muscle. I would say it's within the muscle actually.
With this, we can back here. Let's see. So, if you see on the x-rays here, you can also see there's some bony changes next to it.
Yeah.
Right in here. And here we don't really see the bones very well. CT, there are actually some bony changes right next to this. And this was BCG osteomyelitis. So it's actually inflammation. All the stains were negative, no bacteria were found, and this was thought to be an inflammatory reaction from the vaccination.
And BCG is an excellent treatment for bladder cancer. In fact, that's one of the few that they have. And I went through a series of them. They're hard to find, which is unfortunate. The companies don't make them.
Okay.
But for some reason, they don't make them, probably because of finances. I don't know.
Yeah.
But it's very effective for treating bladder cancer.
Great. Thank you.
And irrigate is done through a catheter. Doesn't cause any symptoms whatsoever.
Yeah, great. So here we can see another mass. It has vascularity within it. This is 4 months later when the patient developed an axillary palpable mass, and this was also BCGitis in the same patient. Okay, Robert.
All right. So we have a coronal and a sagittal, and it looks like there's fatty atrophy of the teres minor muscle.
Right. And so, we see this kind of fairly frequently. You always look to see if there's a mass in the axillary region. And I think only once in many, many years and many thousands of patients that I've looked at, has there been a mass in that location, but you look for it anyway. Sometimes I thought, well, maybe these are old paralabral cysts where the paralabral cyst has gone away and we don't see it anymore. At the recent ISS meeting in London, people thought that this may be just due to prior mechanical stretching of the axillary nerve by an accident, which leads to denervation, atrophy of the teres minor muscle. But I've seen it in some pretty high-level athletes. So trauma certainly could be a cause. Okay.
Usually there's an innervation of the deltoid also with the axillary nerve posteriorly. I don't know whether the deltoid looks normal to you or not, but
it doesn't
look
significantly atrophied to me, right? And the vast majority of time that I see the teres minor atrophy like this, the posterior deltoid looks pretty normal. So maybe it's just a branch that goes off to the teres minor that's in a position where it can be mechanically irritated. I don't know, but it's a common finding. Let me just see. Let me just skip by this. Okay, Robert.
I think he just went.
I can go again. It's fine.
Oh, I'm sorry. Go ahead, Tayson. My error.
Yeah, I mean, looks like there's a posterior labral injury with paralabral cyst projecting into the the spinal glenoid notch.
Okay. Anything else?
I think the posterior capsule is disrupted too, right?
Back in through here.
Yeah.
Certainly see the tear there. There we can see the cyst in the spinal glenoid notch. What else would you look for in a case like this?
Infraspinatus atrophy.
Okay, and then maybe it's a little bit thinned here. The deltoid looks a lot more robust. If we go to the coronal images, we can actually see the difference in signal intensity between the teres minor and the infraspinatus. And as you said, this is acute denervation or maybe subacute denervation of the infraspinatus due to this paralabral cyst that went into the spinal glenoid notch. So that's nerve entrapment. There are a number of places where you can get nerve entrapment. We've already kind of talked about this, so I don't know that we need to go into it too much more. So let's move on here. Let's see. Elior?
Okay, so here we have atrophy of the teres minor.
Here's the right side.
The right side.
Yeah, it just shows.
Sure.
With
Okay.
teres minor atrophy, and what else do you see here? What else would you want to look for?
A lesion in the quadrilateral space on the left side.
And do you see any difference between here and here?
Yes, there is atrophy of the. Well, I'm not seeing the muscle anteriorly. Maybe is that the finding or lipoma. Okay.
Yeah, and of the few masses that I've seen that have been associated with this, this is the most prominent one with lipoma here. And I've seen a few other in the literature where they've had compression of the axillary nerve due to lipomas in this location. And it's also called the quadrilateral space syndrome. And here you can see, here's the right side and the left side with a compression of the axillary nerve and vessels here due to this lipoma, which is not present on the opposite side.
Mm.
And that's quadrilateral space here.
Campbell's mentions 4 or 5 different conditions that can cause it, but I can't remember them all.
Okay.
So maybe I see some edema there's atrophy of the, let's see, that's the subscap? Yes, right here,
Here's the
infraspinatus.
subscap here.
Oh,
Infraspinatus
yeah,
over here.
yeah. So just fatty atrophy of the infraspinatus.
And why do you think this teres minor, maybe trophic,
Uh, yeah, see that. Oh, so it's maybe just a prominent. Oh, it's an osteophyte.
Yeah, that's a big osteophyte that's extending down into the quadrilateral space, producing compression of the axillary nerve, leading to the atrophy. So there can be a number of space-occupying lesions down here, and you can get large osteophytes, as you guys know, with osteoarthritis. So this is one thing to look for.
One of the conditions is trauma, John.
Yeah. Yeah, that's what at the ISS they thought that trauma with stretch injury to the axillary nerve may be the most common, and probably because most of the time we see nothing on imaging, and so that
Arterial thrombosis.
Okay. Okay, Robert.
All right, so we have a boxer with asymmetric pectoralis swelling 2 days after weightlifting. And I do see pretty extensive edema and increasing within the
I think
pectoralis
I think this
muscle.
was Elior when he was visiting Australia.
uh, so I guess I'd be concerned about like a muscle strain.
Okay. So it didn't hurt right away. It took 2 days for it to pain to develop.
So maybe
Notice
like
how
a
the okay.
delayed onset muscle soreness.
Right. So you can see that there's kind of a lot of the edemas along the in-between muscle fibers where the muscle fibers appear to be grossly intact here. That's kind of very typical of this condition. And this is DOMS, or delayed onset muscle soreness syndrome. It has a very good prognosis and can take anywhere from a day or two normally. It typically starts about 48 hours, 36 or 48 hours after exercising. Typically is better within 3 or 4 days, but can be up to a couple of weeks. And the prognosis, again, is very good. Okay, Tayson?
What are we looking at here? Arrow is pointing to the coracoid, or
Well, this is probably the scapula here.
okay.
Let's see a little bit better. And then, so here is so this is the superior scapula. This obviously is the rib cage across here. And this is
Yes.
called scaphothoracic bruxopathy. And of the shoulder joints, one of the bursa that people often forget about is the scaphothoracic bursa, which is between the scaphoid and the rib cage here. So remember that as a possible cause.
Okay.
Okay, so I'm going to end this lecture now, and then you guys, if you could log back in, we'll start the next lecture.
Okay.